Good morning and welcome. Today I am thrilled to welcome Dr. Andrew Beck to speak about his exciting and inspiring work in and with communities to improve child health. Dr. Beck comes to us today from Cincinnati Children's, where he is an associate professor at the University of Cincinnati College of Medicine and an attending primary care and hospitalist pediatrician at Cincinnati Children's. He is associate division director for community health within the Division of General and Community Pediatrics. He is faculty co-lead for community and population health in the Fisher Child Health Equity Center, and he's director of population health research and innovation within HealthVine, the Cincinnati Children's Medicaid ACO. He received his BA in anthropology from Yale, his MD from the University of Pittsburgh School of Medicine, his MPH from Harvard, and he completed residency and fellowship training in Cincinnati. Dr. Beck's research, as we'll hear today, aims to equitably improve child health outcomes by addressing key social determinants of health, specifically focusing on the intersection between neighborhoods and health, and on identifying and addressing population health disparities through clinical community collaborations. Please join me in welcoming Dr. Beck this morning.
All right, well, thank you everybody, both here in the room and online. It's really a privilege to be here, and I'll start with some self-embarrassment, saying that it's really good to be back. This is a picture now from, 21 years ago, almost exactly, almost to the day. This is my father and I at the University of Pittsburgh School of Medicine White Coat Ceremony, August of 2002. And you'll notice that I probably look about the same. My pants have less pleats as we've kind of evolved in our fashion sense, but to be back here in Pittsburgh is really an incredible opportunity and experience for me. And one thing that I hope to do over the course of the next 45 minutes or hour is to think about Pittsburgh in particular as it pertains to how we think about neighborhood, how we think about community, and how we think about population health. So here are my specific objectives that we'll walk through. First, I'd like to define neighborhoods and think about how they link to our sense of community. I'd like to illustrate the importance of neighborhood to a range of child health outcomes relevant across the life course. And then, importantly, I hope we can talk a bit about opportunities for neighborhood-based action, engagement, and improvement. But I'd like to start by conceptualizing neighborhood and community. I'd like to think about what that means to us, particularly in cities like Cincinnati or Pittsburgh that are truly cities characterized by neighborhood presence. And so I'd ask, and unfortunately we don't have the participatory tool working for us this morning, but I'd ask you to think reflectively of when you hear the word neighborhood or when you hear the word community, what word comes to mind, what thought comes to mind, what picture comes to mind? I'll provide, as you're thinking about that, some of the definitions for these terms through HHS and through CDC. One definition for neighborhood is the places where people are born, live, learn, work, play, worship, and age. It aligns in many respects with the definition of community, a specific group of people often living in a defined geographic area who share a common culture, values, and norms, and who are arranged in a social structure according to relationships the community has developed over a period of time. What do you think about those definitions? What do those definitions, what pictures come to mind? What does neighborhood or community mean to you? And then I'd also ask you to consider what neighborhoods or communities that you have meaningful emotional connections with, understanding why. For me, there are probably three that jump to the top of my list. Brighton, New York was where I grew up. It's a town in Rochester, New York. Montgomery, Ohio, on the far side of the screen is where I currently live, a town in and around Cincinnati. And then, of course, in the center is Squirrel Hill, a Pittsburgh neighborhood, which is the place where I lived when I was here, also the home to many of my family members and a long history of my own family here in this particular city. And so I'd like to think about Squirrel Hill for a moment, my personal connection to Squirrel Hill. And as I think about this for me, I'd love for you to think about those neighborhoods or communities that feel similarly to you. Here are some pictures within Squirrel Hill from my own family. The top left, 3 generations of women, my mother when she was an adolescent with her mother and her grandmother, my great-grandmother, all in front of 5426 Darlington Road, the home where she grew up. More pictures with her father, my grandfather with her sister, and then when I was a child visiting that house with my sister in the bottom middle. Picture on the left, a cultural garden also in the neighborhood that was sponsored by members of my family. You see my grandfather on the right, 2 of his sisters and his mother seated below. So a personal connection to a neighborhood that spans generations. One of the books on my grandfather's library shelf, which is now on my shelf, is this one. It's perhaps not a New York Times bestseller, but an important book nevertheless, that started to talk about how Squirrel Hill, in many respects, became Squirrel Hill, looking at a history over many years of the Jewish experience in Western Pennsylvania. And this particular passage comes from that book, and I'll read part of it, that as the Jewish colony in Squirrel Hill grew, more Jewish residents made a living in the neighborhood, from grocery or drugstores, restaurants, butcher or barbershops, or clothing stores. This living in the neighborhood being a part of the neighborhood. And I hearken back to that definition I shared a moment ago, where neighborhood is that place where people are born, live, learn, work, play, worship, and age. That element of community, that defined geographic area, a common culture, values, norms, a social structure, a sense of belonging. Now, of course, we can all fast forward, and I was not in Pittsburgh for the event, but I'm sure many of you were. That same neighborhood experienced that horrific event just a few years ago. And many of you have perhaps seen this book. It probably got a little bit more press than the last one I showed. But a book by Mark Oppenheimer about the Tree of Life shooting and taking a look at that event through the lens of neighborhood, through the lens of community. This particular passage comes from that book where he highlights that everyone used the same supermarket, ate at the same delis, attended the same schools, the public library, the post office, the movie theater, the ice cream shop, the shoe store, the kosher butcher, the synagogues of every denomination. Everyone walked the same sidewalks and for the most part nodded warmly as they passed. Once again, echoing those definitions of neighborhood and community which we saw a moment ago. Now, importantly, the effect of neighborhood or community on health and well-being outcomes is in many respects driven by the balance of assets and risks. Neighborhoods are, of course, not always idyllic. They are not always welcoming or inclusive. They are not always on the receiving end of investment or opportunity. And it's the balance of these assets and risks that influence the health and opportunity for outcomes experienced by residents of those neighborhoods. And so one of the questions we've posed in Cincinnati, which I think could be posed in just about any part of our country, is how do our patients and their families view their neighborhood, the sense of community that those neighborhoods promote or impede? We did an exercise a few years ago where we had families, in most cases parents, in some cases older children, draw a picture of their neighborhood, the conception of what their neighborhood meant to them. Sometimes these pictures were quite positive. Here's one. You see a family drawn close to a home and a tree, a pretty sun. Here's another one. Some of the text might be hard to read, but thanks for the lookout, no problems here. They have a job fair, welcome to the neighborhood, something positive. Here's one that perhaps is a little bit more negative. This is in a neighborhood that was undergoing what some may call gentrification, others may call displacement. Houses on my street with a crane knocking them down. Another one, this one particularly stark. There was, on the back of the drawing was this particular quote from the person that had made this drawing, that they were depicting a shooting that was occurring during the day. They're used to the sound of gunshots. And then those cars People speed by my house on a drag race, and you can see the bottom, part of it cut off, but saying that that neighborhood was like the Wild West. Another one, also a little bit more negative. You see the top, a quote that's, "I wish the killing would stop. I'm afraid to go out and play. Move out of the way. There's a shootout. There are drugs being sold." And then to bring it even closer to home here, or in Cincinnati, you see children's depicted right there as this individual lived in the neighborhood that essentially encircled Cincinnati Children's Hospital. We've also done some qualitative work trying to generate insights from hospitalized parents, and we looked at those insights based on the degree of poverty in the neighborhoods in which those residents lived. And so some examples of this, a quote from a family that was living in a more impoverished neighborhood, that it's impossible to be at the hospital 24 hours a day. I don't care who you are. I don't care if you're a single parent. The challenge still exists for those from the less impoverished neighborhoods, but perhaps they look a little bit different. I'm still doing laundry. I haven't cooked at home in 2 weeks, but the kids are back on track. I'll eventually get there, but the kids got to get back on track. Thinking about leeway and the differences in leeway depending upon where you live and what those lived experiences look like. One noted that it takes about 4 hours to get to the pharmacy, 2 hours to get there walking, 2 hours to get back. I just can't do it. Whereas on the flip side, one noted that a nurse asked me, if you call your pediatrician's office, can you get in within 48 hours? And my response was, yeah, with a sick kid or a follow-up, they'll get you in the same day. Maybe that's not the same access depending upon where you live and what resources you have access to. And speaking of resources, a last example here, one noted that they were pretty plumbed out from the hospital admission, some challenges that accompanied them home. This particular respondent was a mother who had just delivered a newborn baby, but was hospitalized with her older child, who I believe was 3 or 4. She was in the hospital with no money, no food, no gas, basically eating nothing but cereal or a little scrap that her child doesn't eat that she could sneak in before the doctors come and see her. So these are voices of families in our hospital, and I almost guarantee those same voices bubble through here in Pittsburgh. Whereas another one noted that my work worked with me a lot, my employer let us work from the hospital. So what is the leeway, what is the difference in effect of a hospitalization on different individuals and populations? So how might we learn from neighborhood or place? I've provided some pictures, some qualitative insights, but I think there are other ways we can take insights from neighborhood, from place, from community, and use that to understand how we might affect change. We've done a lot of work with geographic information systems, which I'll define in a moment, but we've used place-based data to define spatial variation in assets and risks, in the balance between those assets and risks, in ways to define inequities. We pursued analytic studies, assessing associations between place-based risks and assets and outcomes, sometimes using this for pattern recognition, understanding when it's appropriate to look at it as a proxy for individual level data and when it's more a marker of one's context. You can use it for prediction. How might different risks or assets present at a place-based level help to understand risk presence at an individual level? How might it characterize populations? How might it inform our assessment of outcomes or events that could come subsequently? And lastly, we've often used it for adjustment. How might we think about these factors to assess unmeasured or insufficiently measured variables, differences, or confounding? A few more terms that I'll introduce before we get into some of what these data show. Geographic information systems, I mentioned a moment ago. These are systems that capture, store, analyze, manage, and then present back data that are linked to a specific location, so geospatial information. Geocoding is the assignment of a code, often numeric, to a geographic location. We often think of zip code. We've been talking a lot today about neighborhood. I'll introduce some data in a moment about census tract, which are certain geographies that the US government, the US Census often will use to characterize certain communities. Shapefiles are those files that describe those geometries. They can be points, they can be lines, they can be polygons that show up on a map. And geomarkers, which is a term we've often used to align with something like a biomarker, is an objective, contextual, or geographic measure that influences or predicts the incidence of outcome or disease. Okay, with some of those terms, I wanted to then begin to discuss the bridge between neighborhood and health, some of the data to link these two components, and then ultimately how we might use those linkages to move toward improvement. And my next interactive piece, which isn't going to quite work here, but maybe if there are some people in the audience who want to just shout it out, so what is your favorite bridge in Pittsburgh? You could probably guess what mine is based on the slide that just came. But does anyone have a favorite bridge in Pittsburgh?
Fort Pitt.
Fort Pitt? Yeah. On account of the view. I'm partial to Smithfield Street, and maybe Roberto Clemente is second, but there's a lot of great bridges in Pittsburgh. So, okay, so the bridge between place and health, between neighborhood and health, perhaps slightly different than Fort Pitt or Smithfield Street or Clemente or Hot Metal. There are very real connections between place and health, and we are not new in describing these links. In fact, I went back and found this particular quote from Hippocrates' publication on airs, waters, and places. And though I think there are some things we can disagree about his characterizations, the fact that he was writing about the influence of the air we breathe, the water we drink, places on people in the 5th century BCE illustrate that the intersection between place and health is not something that is new. And I'm not going to read this whole quote, but I'll just highlight a few pieces. The mode in which the inhabitants live and what are their pursuits. This is the part perhaps that's maybe a little judgy on the part of Hippocrates, but whether they are fond of drinking, eating to excess, given to indolence, or fond of exercise and labor, not given to excess in eating and drinking, all then influence health outcomes. And he also had full chapters in this particular publication on the effect of the environment, water, air, etc., on health outcomes, kind of a early rendition of the effect of environmental justice on health outcomes. The intersection then between health and place, of course, continued to transpire over the many centuries thereafter. And then the early maps that perhaps some of you have seen emerged in the 1800s. The map on the right comes from Edwin Chadwick, looking at linkages between life expectancy and poverty. And this is an early GIS where he overlaid some of the factors in the city of Leeds to understand some of those links. He went deeper into distribution of deaths related to cholera and respiratory disease, how it linked to elements of poverty and work. These data layers being used for inferential purpose very early on. And many of you have probably seen a map that came about a decade later from John Snow, looking at the incidence of cholera and distance from infected water pumps. These are all early forays into that health place neighborhood health link. And it's also driven a debate within public health that perhaps some of you have read about or seen, that some people follow the school of thought that of composition, that place and health are linked based on who lives in a particular neighborhood. The concept that it's the difference people make to places as opposed to context, which is the difference places make to people. Now, I would suggest, and I think most people now believe this to be a false dichotomy. It is truly an interrelated duo that I think leads to both being important. And there's a quote from this book, which I strongly recommend, by Kouachi and Berkman, on neighborhoods and health, that people create places and places create people. You really can't separate these out. The composition versus context debate is a false duality. And so if people create places and places create people, I would suggest taking it a step forward, and that those people and those places create outcomes, and importantly, outcome distributions. So another term This one, population health, which is what I spend a lot of my time now thinking about and working on. This definition comes from this paper in the AJPH that's now about 20 years old. And it highlights the health outcomes of a group of individuals, including the distribution of such outcomes within the group. So importantly, it looks both at what, say, the average is, but also what the spread is. So to achieve population health, not only do you need to affect that average, but you need to narrow or ideally eliminate gaps. How might we think to get there? Well, one of the things we might do is population health research. This term was defined by Keyes and Galea just a few years ago as the study of the conditions that shape the distributions of health within and across populations, and of the mechanisms through which these conditions manifest as the health of individuals. And so I'll highlight three pieces of this definition here. Conditions, that very much intersects with our conception of community or neighborhood. The distributions, what affects inequities or disparities in outcomes that we see, and then the mechanisms that underlie those, which may in fact represent targets for intervention. So let's think about conditions. So this term has been used increasingly in the medical literature, in public health, this concept of the social determinants of health. But this term is as old as time. It is as old as what we saw from Hippocrates a moment ago. This particular definition comes from the World Health Organization, which is simple in that the social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And you can see that the definition goes on to define some of those systems, some of those policies that influence and in many respects determine the determinants. The picture on the far side of the screen comes from Healthy People 2030, illustrating ways in which one might think of the social determinants of health in domains. You could see healthcare access and quality, neighborhood and built environment, social and community context, economic stability, and education access and quality, all components which may influence the way in which we think about those conditions. And before I move on from this, you see that start of the definition, the conditions in which people are born, grow, work, live, and age, and that in many respects aligns very closely with the previous definition of neighborhood, the places people are born, live, learn, work, play, worship, and age. So in many respects, one cannot dissociate the social determinants of health from neighborhood, from the place in which we find ourselves. And what about distributions? I mentioned inequity. Well, here's a definition of health equity, this concept that everyone has a fair and just opportunity to be as healthy as possible, requiring the removal of obstacles to health, such as poverty, discrimination, and their consequences. So this idea of population health, where we're pursuing fair, just distributions of health outcomes, is in essence the same as the pursuit of health equity. And then mechanisms. So here is a figure looking at some of the factors that in many respects will determine ways in which individuals experience health outcomes. And there's a gradation. One might start by thinking about social risk factors or social needs. That could be hunger, that could be food insecurity, those elements of life that may get in the way of the achievement of health. I imagine that in many of your clinics, on many of your inpatient units, you're already doing those assessments, be they formal or informal, for health-related social risks and social needs. They, of course, align with social determinants of health, the food desert or the food environment linked to the experience of food insecurity. That picture was taken a few years ago by some of our residents in the quote-unquote produce section of a corner store in one of our neighborhoods that lacks a grocery store. And you wonder why eating fresh produce is rare in some communities compared to others. And of course, the determinants of those determinants, and in turn, the risk factors and needs that may be linked to them relate to structural factors of health equity. Think structural racism, generational disinvestment in certain communities, that takes more of a population or community-based lens. And so how does this then translate to health outcomes? The this is a map that I created using CDC data that's now available at small geographies. Not every geography, as you can see, certain census tracts or communities, neighborhoods in Pittsburgh are not depicted on this, but this is a life expectancy map. And you can probably see the geography. The rivers certainly make it a bit easy. The H is where we're sitting right now. Red represents those communities with lower life expectancy. Green and blue represent those with higher life expectancy. And I called out a few. I believe it's the Hill District has a life expectancy of 68 years. Some of the suburbs to the south and west have a life expectancy of 83 years. So a 15-year life expectancy gap separated by just a few miles and maybe a bridge or two within this particular city. We're going to come back to this map in a moment, but it's not just life expectancy. Life expectancy is a rather crude measure that includes a number of different factors. But in pediatrics and child health, we think about all sorts of different measures. And so this isn't a map, but it's an example of hospitalizations for ambulatory sensitive conditions. This is some work we did in Cincinnati with collaborators at Kansas City, where essentially we took all admissions to Cincinnati Children's and to Mercy Kansas City Hospital, and we focused on these particular conditions that you see on the left, which are considered ambulatory sensitive conditions whose morbidity should at least theoretically be preventable to a degree. And then we calculated admission rates by quintile of census tract using something called the Child Opportunity Index. Perhaps some of you have heard of this measure. It's available nationally at census tract and zip code levels. And it characterizes the environment based on educational opportunity, opportunity related to health and environment, and opportunity related to social factors and economics. And you can see at the below some of the types of measures that find their way into this particular index. Now, the thing I want you to look for, even more so than the actual numbers, are the gradations, are the stepwise decreases in admission rates across each of these conditions as you go from red to yellow to green. So if you take asthma on the top, just as an example, the admission rate within the very low tracts was about 6 times that of the very high tracts. And this same pattern flowed for bronchiolitis, for pneumonia, for cellulitis, diabetes-related admissions, gastroenteritis, seizure, and UTI at the bottom. Of course, some were more common reasons for admissions than others, but the gradations, the stepwise changes were ever present. These are similar data now just from Cincinnati Children's Hospital, where we looked at similar diagnoses based on poverty, quintiles of neighborhood or census tract. There's a map of our particular neighborhood. The H is where Cincinnati Children's is located. Avondale is that neighborhood that I mentioned a bit earlier that is just to our north and to our east. And the dark red represent essentially hotspots of hospitalization across all causes. But importantly on this map, and in many respects like Chadwick or Snow, we start to also overlay additional elements which help us to think about context. So on this map, we start to think about risks and assets. We have primary care and school-based health centers, we have schools, we have pharmacies, and on other versions of this map, we may have additional factors like housing code violations or episodes of violent crime or presence of health care shortage areas as defined by the federal government, all elements that help us begin to understand patterns. So in understanding those patterns, here's another figure, and don't worry, I don't need you to take a magnifying glass to that list on the far left, but let me show you what you're looking at. This is looking at what we call an all-cause inpatient bed day rate. So we took every day a child spent hospitalized at Cincinnati Children's. We mapped each of those days to a particular Cincinnati neighborhood, and then we calculated an inpatient bed day rate normalizing by population, so the number of kids that lived within each of those neighborhoods. So the y-axis that you're looking at now are all 80 or 90 neighborhoods that compose Hamilton County, Ohio. That's greater Cincinnati. And the x-axis is that inpatient bed day rate. Now, if anyone's from Cincinnati and you're really curious, I'm happy to go through some of them in a moment, but we tried to think about patterns, and so we just cut the city in quartiles: gray, pink, purple, blue, and green, and then looked at a range of census data to think about how gray neighborhoods differed from green neighborhoods. And here are some of the results. Box and whisker plots of the distribution of certain census variables that were calculated from the distribution within each of those quartiles. And some of these may be hard to see, but the importance is that each is stepwise. I'll highlight a couple in a moment, but just to start, you see the ramifications of structural racism percolating through these data, the economic and racial segregation that characterize Cincinnati like it does so many other cities, where the proportion of individuals within those neighborhoods in gray were far more likely to be disproportionately identified as Black or African American. You can see similar data as you go through this figure: stepwise rates relating to female-headed household, no more than a high school education, no vehicle in the household. In Cincinnati, probably like Pittsburgh, is a city where having a car is almost essential to really getting around. Children living below the federal poverty level, households on public assistance, renter rates, unemployment rates, and rates of vacant housing. Let's think about that first, the first set of box and whisker plots, and think about what underlies that fact. And in many respects, you can't think about that without thinking about codified structural racism that in many respects emerges from hundreds of years of discrimination in this country. And so I imagine many of you are familiar with the concept of redlining. Perhaps many of you have seen the map depicted on the left. This is the redlining map I found for Pittsburgh from this really incredible site put together by the University of Richmond. The URL is down there, but I encourage you to take a look. They have a library of redlining maps for cities all across the country. So here is this particular map looking at the redlining practice. For those not familiar with redlining, it was a practice in the 30s primarily, where essentially through legislation, lending became far more difficult in certain neighborhoods than others. And it became far more difficult in many respects because of overtly racist characterizations of those particular neighborhoods for lending security. And so a couple quotes that I just want to pull up that come directly from the University of Richmond site that were associated with this particular map. One for that same neighborhood that I highlighted a moment ago on that life expectancy map. You recall that the life expectancy was 68 years. You can see the quote that's overtly racist characterizing that particular neighborhood and assigning it a red or low level of lending security. Now, how about that other neighborhood I highlighted, which currently has a life expectancy of 83 years, a far different quote, which then leads to differential home ownership rates, differential investment in neighborhood that continue to this day. So what are the side effects beyond life expectancy of these types of practices? So clearly we still have issues with 15 years worth of life lost in some neighborhoods than others because of this type of practice, but it also affects pediatrics. Here is some data we looked at for essentially trying to calculate the excess admissions experienced by Black or African American youth in Cincinnati as a result of these types of discriminatory practices. And so we looked at the top 30 reasons why kids were hospitalized at Cincinnati Children's. Some of these probably could be grouped with one another, but these were the quick poll from our electronic health record. And using population denominators, we were able to essentially say, if Black youth in Cincinnati had the exact same hospitalization rate across these conditions as their non-Black peers, how many admissions would we need to prevent each year? And so just take that top bar, 294. So every year, essentially we would need to prevent 294, almost 300 hospitalizations for asthma among Black youth in Cincinnati for them to have the exact same hospitalization rate as their non-Black peers. A huge difference. And clearly some of these other diagnoses are less common, but you see that even for something like COVID-19, we had 12 excess admissions in this particular case. And it goes across infectious causes, chronic causes, acute on chronic, a side effect of multi-generational racism that is emblematic of continued disinvestment in certain neighborhoods and communities. Now, we tried to take this one more step to think about causal inference and to provide more evidence for what we probably already know to be the case. We sought to estimate neighborhood-specific racial disparities in hospitalization rates across all causes, once again, and then to determine how much is mediated by neighborhood-based exposures. And so we use something we call, or something called a directed acyclic graph. This is a tool often used in epidemiology and public health to think about relationships between exposure and outcome, and to then think about mediators and confounders of these relationships to inform how and when you adjust for certain factors, to then allow for the so-called counterfactual interpretation of cause and effect. What would be the case under different circumstances? For those interested, there have been a number of studies and thought pieces published about this method that I think are quite good reads. But for our particular approach, we started with youth less than 18 years of age, hospitalized at Cincinnati Children's, again, over a multi-year period. We included data from Hamilton County, which is our main county. It includes 226 census tracts, about 190,000 kids. We geocoded all of these events, merged those geocoded addresses with neighborhood data using a tool called DGAUSS, which is a HIPAA-compliant geocoder and geomarker assessment tool. The outcome of interest was the census tract hospitalization rate measured per 1,000 children per year. And the exposure was a variable that we thought of as membership in a marginalized racial or ethnic group, conceptualized as emerging from complex historical processes, read structural racism. This was a census variable looking at the percentage of individuals within a particular census tract who identify as a race or ethnicity other that was non-white or Hispanic. So here is our DAG, our directed acyclic graph, again, starting with those complex historical processes, going all the way to hospital admissions on the right. We essentially conceptualized most of the effect of neighborhood as occurring through measures of socioeconomic status, some of which we had good measures for, others which we had perhaps proxies for, and then a lot of the effect occurring through that residential neighborhood box, which in turn affected hospital access, socioeconomic deprivation at a community level, and environmental pollutants and amenities. Now, our adjusted model sought to essentially block these pathways and understand the degree of effect that we were explaining by adjusting for these factors. And here are the data. We did this across all causes: asthma, type 1 diabetes, sickle cell disease, and psychiatric or mental health admissions. The red circle is an unadjusted racial disparity rate ratio, and the blue triangle is the adjusted direct racial disparity rate ratio. And the data are this, that across all causes, you explain nearly 100% of the disparity by assessing, addressing, adjusting for factors relating to socioeconomic status, the environment, healthcare access. Those residential neighborhood factors that we've long defined here as the conditions, as the place in which someone lives, grows, works, and ages. Okay, so we have this bridge between neighborhood and health. We know there to be effect. We know it to be delivered and experienced through a range of exposures. What can we do about it? And this is, of course, Pittsburgh, so let's do a Mr. Rogers quote, that in every neighborhood all across our country, there are good people insisting on a good start for the young and doing something about it. And what I'd like to close with in these last 10 minutes or so are neighborhood-based action, engagement, and improvement. And the last semi-interactive thing that we won't do that I'd ask for all of you to reflect upon is what neighborhood or community partner do you already work with or do you wish you worked with more? And these are the types of questions that I think are important for us to ask as members of the healthcare field. Now, there are a few ways to move in this direction. Probably many of you, as I mentioned before, are asking meaningful questions as part of a social history or a social screener. The National Academy of Medicine now recommends we all do this in a standardized way, collecting certain variables to help us assess inequities, but also to move toward intervention, assessing factors like educational attainment, financial strain, stress, depression, and more, integrating social needs screening and social determinants of health data within the electronic health record. And of course, the AAP encourages this too, to facilitate prevention services and to, importantly, improve the health of all children, in bolding. Now, I would say screening is important, but merely screening is wholly insufficient, and it must be matched with effective action and intervention. One of the things that we've sought to do, in addition to the social needs screening, is to think about how certain place-based data, neighborhood-based data, can be linked to meaningful actions. And so here's a table we put together that thinks about certain place-based data and what some interventions could look like that are tied to them. And I'll just highlight one of them, map of Avondale. The background here is, in essence, looking at asthma utilization rates, ED visits and hospitalizations, and we've started to overlay things like housing code violations. And so housing code violation data are present within our health and building department record. We've started to think about and look at what those data could inform, including connections to housing inspections by public health sanitarians and building inspectors, and through legal advocacy, often delivered by our Legal Aid Society. And some of what we've done in this space is begin to integrate direct referrals to these community partners from our electronic health record. Our partnership with Legal Aid is perhaps the most mature. We have what we call the Cincinnati Child Health Law Partnership, or Child Help. And this links patients primarily from our primary care centers to legal advocacy for risks or needs related to public benefit denials or delays, to educational resources, to housing-related risks present within their particular unit. One thing that we recently did was essentially emulate randomized trials of the deployment of legal advocacy through this partnership, using data from referrals made over the last 10 years, matching on age, referral date, concurrent visit, prior hospitalizations, and adjusting for remaining differences between patients who did and did not receive the intervention. And the results are displayed in this chart here. So this y-axis is looking at hospitalization rates either before or after the intervention. The orange box and whisker plots represent those who received the intervention. The blue represent those who did not. And really what we found was that those who received a legal aid intervention had a hospitalization rate 38% lower in the year after referral compared to those who were not referred. So meaningful change in health outcome by a intervention directed toward the home environment. This partnership with Legal Aid and with the city has also helped us move from patient to population, from, say, individual housing unit to broad apartment complex. This is a map of Cincinnati, which we put together with the city of Cincinnati, looking at clusters of housing code violations related to triggers for respiratory disease. Yellow tend to be those that are more dense. You can see a certain cluster of yellow in the center right in that Avondale neighborhood in close proximity to our hospital. There was another cluster that we found that paired with reports from patients and families that we were seeing in our center identified a particular apartment complex that had fallen into disrepair with many outstanding housing code violations and an unresponsive predatory landlord. And fortunately, by overlaying some of these data elements, this pattern was recognized, And the city is actually filing suit against this landlord currently, and the litigation is ongoing, but we've already started to see improvements in those conditions and a very strong likelihood that within the coming weeks that building will go into receivership and will find a new owner which will meet their needs and requirements for healthy housing. We've also taken a population neighborhood-based view of quality improvement. This is a project that we conducted in the Avondale and Price Hill neighborhoods, where we started to think about what would it take to reduce the number of days kids in those neighborhoods were spending in our hospital, again, focused on pursuing better outcomes and narrowed gaps. We started small, one neighborhood, then two, and then we're starting to think about ways in which to extend still more. Strategies related to providing proactive outreach within this neighborhood, equitable resource deployment, including healthcare-based resources like care managers and community health workers, as well as community-based resources like housing inspectors and legal aid. And to date, we've found the improvement you can see on this run chart over time, a decrease that has resulted in about 150 fewer days, 80 fewer admissions every year from this neighborhood, days that kids are spending at school, parents at work, doing the things that parents and kids should be doing and not sick on our hospital units. And importantly, the gap with the rest of the city cut by nearly 50%. So what is needed to take this to scale? So we started with one, then two neighborhoods. How do we take it to an entire city? One of the things that we've started with is identifying what a shared population looks like and what a shared vision for that population looks like. So if you take our entire primary service area, there's about 500,000 kids, probably not too dissimilar from metropolitan Pittsburgh. Some of the areas where we're starting is a subset of that population that are now insured through a value-based payment mechanism called Health Fine, contract with Medicaid that now covers about 120,000 kids, allowing us to do something different and perhaps better in a value-based model than a fee-for-service model. This is aligning with the margin aspect of what our objectives are. We also have a new Child Health Equity Center, which is testing interventions to then move towards spread, focused initially on the 10 most structurally disadvantaged neighborhoods in Cincinnati. So this is beginning to align margin and mission. Inside the hospital, we've developed what we call the Health Equity Network, again, identifying what our shared purpose is, in this particular case, reducing inequities in child health outcomes, defining our population, Cincinnati youth, initially thinking about hospitalizations, but extending that to other outcomes as well, enumerating a denominator so we understand our accountability for a population. In this particular case, we're thinking about all youth within greater Cincinnati, though we are starting to subset and pursue rational segmentation to help us learn more quickly. We're devising theory. We're using quality improvement methods to co-produce shared drivers with parents, with families, community partners. We're identifying scalable units, understanding that it's sometimes okay to start with an individual clinic, individual neighborhood, and then move our way towards something broader. And then we're testing and we're learning every day. One example of this is theory that is being developed by what we call the community table. These are convened leaders from across Cincinnati, from the business community, the public sector, community-based organizations, parents, families, youth, thinking about what would it take for all children to thrive in Cincinnati. We are thinking about what are those drivers, some of which are health care related and some of which perhaps are not, but could certainly have an implication for health outcomes. What are some data that we need to think about what thriving means? Some of these are health outcomes, maybe preventive care outcome variability across our neighborhoods, but some of them may be educational. The bottom right chart is the percentage of children who are entering Cincinnati public schools ready to learn come kindergarten. And we're starting to then translate these bar charts to run charts and thinking about how we may move those outcomes in meaningful ways. We do so upholding core principles that equity is foundational, children and families remain central to our work and part of the work, in that we work together on building solutions, relationships, and trust, and do so humbly, understanding that every one of us has something to teach as well as something to learn. We also understand that we're action-oriented and sustainable results-focused. At Cincinnati Children's, you'll find many of our data displayed on run charts or control charts, understanding what happens every day, every week, every month, to understand whether we're truly meeting the moment. What does this look like in practice? This picture actually was just taken last weekend at a session where about 15 of us gathered to think about what would it take to truly achieve thriving for children within one particular neighborhood. I don't expect you to read it by any stretch, but the thing on the whiteboard in back of this group was what's called a causal loop diagram that we created together in thinking about those factors that either could support thriving or impede thriving within that particular community. We're now taking what we did there and beginning to translate it into leverage points. What might we do to move some of those components of that figure? And in large part, what this means is reorienting our thinking towards what we call systems thinking and connections between system members and partners. Some of what we do in healthcare is essential to that system, but it is far from the only component of that system. For kids to have the opportunity to meet their full potential, to thrive, to be well, to be in school, there are things we need to do in medicine to contribute to that, but so too are there things that we might contribute and support to leaders in the educational sphere, in the community-based organization sphere, in city government, in the business community, all to build around an approach that identifies those common measures, objectives, and methods that will build us in the direction of better, more equitable outcomes. We're trying to do this in ways that in many respects follow the culture change that many of us have seen in healthcare around safety. So we live and breathe a culture of safety in our hospitals. How might we also live and breathe a culture of equity that pushes us in the direction of those better, more equitable outcomes? And then as financing mechanisms change, how might we more effectively merge mission with margin, pursue this virtuous cycle where we invest in that which will build both capability and capacity and eventually shared savings for better outcomes for those in which we care for. So I want to conclude with a few quotes and thoughts that I think in many ways meet the moment, that push us to think about whether it be Cincinnati or Pittsburgh or any other city or part of our country, what pushes us in the direction of consistent, meaningful collaboration with neighborhoods and communities for population health equity. I imagine some of you were at pediatric academic societies in DC a few months ago. I brought my family, and part of the time I was at the conference and part of the time I was exploring DC. And we went to the Smithsonian's African American History Museum. There were two quotes that I thought were particularly that really moved me. One from an activist, Majora Carter, who noted that no one should have to move out of their neighborhood to live in a better one. And to me, I take from this the fact that neighborhoods can lead to premature death. We've seen that in our data, but so too can they promote long, healthy, meaningful, and productive lives. A second quote from Ralph Ellison, who noted that it's not geography alone which determines the quality of life and culture. These depend upon the courage and personal culture of the individuals who make their home in any given locality. This place makes people, people makes place. And in many respects, neighborhood-based assets and connections tip the balance toward life, health, and opportunity. And I'd like to close with one last quote. And I imagine many of you know at least one person on this picture. The other person on this picture is somebody named Jacob Rothschild. He's a child of Squirrel Hill. He was educated in part at the University of Pittsburgh. He was my grandfather's college roommate. He went on to be a rabbi in Atlanta and a close friend of Martin Luther King. That close friendship resulted in very real ramifications for his congregation. This was a bombing that was at his synagogue for supporting and being friends with Dr. King. In the sermon he gave in the first service following this bombing, he said these words: "This despicable act has made brighter the flame of courage, renewed in splendor the fires of determination and dedication. It has reached the hearts of men everywhere and roused the consciousness of a people united in righteousness. All of us together shall rear from the rubble of devastation a city and a land in which all men are truly brothers and none shall make them afraid." And from this, I take this conclusion, that out of inequity, inaction, and discord that are generations in the making, can come justice, progress, and community, can come health and opportunity for kids and their families. So I want to acknowledge a ton of people, groups, individuals who are behind a lot of the work that you've seen here. I also want to acknowledge some of my faculty from Pitt Med many years ago, some who are still here and some who have perhaps moved on. And once again, thank you for the opportunity to be here today, and would welcome any conversation that we could have about these topics or any others. So thanks again.